Welcome back to the Cardiology Knowledge Hub, everyone. I'm Dr. Shema Izadon, cardiology consultant over at El Sheikh Zayed Specialized Hospital. Today, we are diving deep into Echocardiographic Windows. This is lecture 2 of our basic echocardiography course, and honestly, I am absolutely thrilled to guide you through this masterclass explainer. Listen, whether you're a first-year cardiology resident, a fellow, or a junior consultant just polishing your skills, mastering your echocardiographic windows is the absolute bedrock of diagnostic cardiology. You literally cannot build the house without this foundation. So let's get right into it. So here is our roadmap for today. We are going to start with a quick intro to windows versus views. Then we'll break down the peristernal long axis, move on to the peristernal short axis and the right ventricular outflow tract, tackle the apical views, really focusing on that 3-chamber, and then wrap the whole thing up with subcostal windows and some extremely high-yield clinical pearls. All right, section 1. Intro to Echocardiography Windows, the true foundation of cardiac imaging. Okay, so I see this mix-up all the time with beginners. People tend to use the words window and view interchangeably, but they are absolutely distinctly different things. Think of it this way. A window is purely the anatomical location on your patient's chest wall. It's the physical real estate where you actually place your transducer. A view, on the other hand, is the specific internal cross-sectional image you capture on your screen. It's like looking through a keyhole. The keyhole itself is your window, but the view is what you actually see inside the room, which totally changes depending on how you angle your eye. Make sense? To successfully evaluate the heart, we basically have a structural framework made up of 4 standard echocardiographic windows. First up, the peristernal window. This gives us our long and short axis views, plus right ventricular inflow and outflow views. Second is the apical window, which is where we hunt down our 4-chamber, 5-chamber, 2-chamber, and 3-chamber views. Third, we have the subcostal window, yielding long axis, short axis, and bicable views. And finally, the suprasternal window. Mastering these 4 specific locations on the chest is your ultimate tool for bypassing those pesky anatomical obstacles, like ribs and air-filled lungs. Moving right along to section 2, the peristernal long axis. This is your standard starting point for every single exam. Now, before you even look at your monitor, you have to realize that patient positioning is literally everything. You want your patient in the left lateral decubitus position. Why? Well, rolling the patient onto their left side allows gravity to pull the heart closer to the chest wall, and at the same time, it drops that left lung away from the midline. This is a game changer because it significantly reduces lung artifact, giving you a much, much cleaner image. Then you're going to place your transducer right there in the 3rd to 4th left intercostal space, directly adjacent to the sternum. So, your probe is on the chest in that 3rd or 4th intercostal space. What's next? Precise spatial signposting. You have to make sure that the transducer marker, or the knob, is pointing directly toward the patient's right shoulder. This exact alignment slices the heart beautifully along its long axis. Imagine a blade going straight from the right shoulder down to the left flank, slicing neatly through the right ventricle, the aortic root, and the left ventricle. It's stunning when you get it right. And this view? It becomes your absolute gold standard for linear measurements. The peristernal long axis should be your go-to for routine linear M-mode measurements of the left ventricle. We're talking the septum, posterior wall, ejection fraction, and internal dimensions. You'll also use this spot for the right ventricular outflow tract diameter, left atrial diameter, and aortic root dimensions. Now pause and think for a second. Why do we take these specific measurements right here? Well, it's because in this view, the valvular motion and the walls of the heart are sitting completely perpendicular to your ultrasound beam. And in the world of ultrasound physics, perpendicular alignment equals the best possible, most excellent spatial resolution. It's just a fundamental rule. All right, let's jump to section 3, peristernal short axis and the RVOT, how we obtain cross-sectional views. Before we go spinning the probe around, pause and think again. We just sliced the heart lengthwise, right? So how do we get a cross-sectional slice without completely losing our acoustic window? The secret is all in the wrist. To get the peristernal short axis view, the PTSAX, you maintain your exact position on the precordium from your long axis view. Seriously, do not slide the probe. Just simply rotate the transducer marker exactly 90 degrees clockwise toward the patient's left shoulder. That simple 90-degree twist shifts your ultrasound beam from slicing the heart end to end to slicing it cross-sectionally. Think of it exactly like slicing a loaf of bread. Once you've made that rotation, you can now sweep your beam through the heart to view 4 distinct imaging planes. You've got the basal plane at the level of the aortic valve, the mitral valve plane, the mid-papillary muscle plane, and finally, the apical plane. Now, here is a massive practical tip for when you're actually out on the wards. Simply tilting the probe isn't always going to cut it. Movement across several intercostal spaces, literally sliding the probe physically up or down a rib space, might be totally necessary to capture all 4 of these short axis planes perfectly. It really all depends on your individual patient's anatomy. Next, let's talk about the right ventricular outflow view. To get this one, you start from your standard parasternal long axis position. Then, you tilt the transducer superiorly and just slightly laterally toward the left shoulder. This angled sweep practically opens up the right ventricular outflow tract for you. It brings the pulmonary valve, the main pulmonary trunk, and the pulmonary artery branches into beautiful, crystal clear visualization right there on your monitor. Let's lock this in with a super high-yield clinical pearl. Why does this specific RV outflow view matter so much? Because in clinical practice, this view is absolutely critical for assessing pulmonary hypertension. It allows you to evaluate the pulmonary valve for specific Doppler profiles that are directly associated with elevated pulmonary pressures. On top of that, it's absolutely essential for catching congenital heart diseases that involve the right ventricular outflow tract. So, bottom line, never ever skip optimizing this view on a dyspneic patient. It's a lifesaver. Section 4 already. Apical views. We are going to specifically focus on the apical 3-chamber. Listen, getting a pristine apical 3-chamber view requires some real discipline. Step 1. You must always begin with a solid apical 4-chamber view. Make sure your left ventricular apex is perfectly centered on the screen and you have absolutely minimal foreshortening. Once your 4 chambers fully locked in, you're going to rotate that transducer counterclockwise. You'll pass right through the 2-chamber view, and usually with a total rotation of roughly 90 to 120 degrees counterclockwise from your original starting point, boom, the 3-chamber view will just suddenly open up right in front of you. When you hit that sweet spot, that 90 to 120 degree rotation, the apical 3-chamber view comes into gorgeous focus. Some people call this the apical long axis view, by the way. Notice how the left ventricular apex sits right at the top of the sector. From there, you can clearly map out the infralateral wall, which is your posterior wall, and the anteroseptal wall. And right there in the middle, you get unparalleled visualization of both the anterior and posterior leaflets of the mitral valve as they open straight into the left ventricle, situated right next to the aortic root and the left atrium. It is an absolute powerhouse of a view for evaluating structural integrity and checking your color Doppler flow all at the same time. All right, final stretch. Section 5, subcostal windows and some high-yield clinical pearls to wrap us up. The subcostal window. You place your probe just below the xiphoid process, and let me tell you, this is arguably your ultimate rescue window, especially if you're working down in the ED or the ICU. From right here under the ribs, you can visualize all 4 chambers of the heart, but more importantly, it is hands down the best window for looking at the pericardium and rapidly detecting life-threatening pericardial effusions. Because of the unique angle, it's also incredibly accurate for measuring your right ventricular free wall thickness. And as a huge bonus, you use this exact same window to evaluate the great vessels in the abdomen, specifically looking at the inferior vena cava to assess your patient's volume status and right atrial pressures. Now, let's do a really quick clinical pearls and exam tips recap before we finish. This right here is a concept that is tested on board exams all the time, and it's a vital bedside truth. The parasternal long axis view provides excellent spatial resolution strictly because the valvular and wall motion is perpendicular to the ultrasound beam. Always remember this golden rule. Parallel alignment is what you want for Doppler velocities, but perpendicular alignment, that is your gold standard for 2D imaging and precise linear structural measurements. Wow, okay, we have covered a tremendous amount of ground today, from the very basic fundamental differences between windows and views, to the precise physical mechanics of how we rotate the probe, all the way to those high-yield clinical measurements. Mastering transducer rotation truly is the key that unlocks the heart's anatomy for you. So I want to leave you with a question to carry into your clinical practice this week. Based on the spatial awareness we've just built together today, which specific view are you going to consciously practice optimizing on your very next shift? Think about it. Thank you so much for joining me here in the Cardiology Knowledge Hub. Keep practicing and keep striving for that perfect image. I'll see you in the next one.